questions are actually pre-specified. We have several experts from Taiwan who were asked to provide questions regarding IO therapy for GU cancers. And actually, Dr. Quinn has reviewed all the questions, and I believe Laura did also. And I would like to thank Dr. Quinn for, actually he had spent a lot of time preparing answers for these questions. He has also put in a lot of information, figures, data into the slides so that we can use these data, slides, results tomorrow for the annual meeting. So let's start with the first one. Today we have three major topics. The first topic will be when to treat patients with immunotherapy, with cancer immunotherapy. And the first question is like this. It's actually a general question about immunotherapy. According to current data, what is the role of immunotherapy in the following scenarios? We have a lot of here. And adjuvant therapy for high-risk urothelial cancer, first-line treatment for MUC in combination with chemo, MUC first-line monotherapy, maintenance therapy, second-line MUC treatment, and any potential to move these therapy forward in patients with non-metastatic, non-muscle invasive bladder cancer and muscle invasive bladder cancer. Dr. Quinn, please.
So this is in the setting of the question about non-muscle invasive bladder cancer and also confined muscle invasive bladder cancer. And I've outlined some trials there that are of relevance. And just to say, there's no current clinical role for this outside of a clinical trial. We have a very large international adjuvant phase 3 study of atezolizumab versus observation that may be running here in Taiwan. It's about to complete accrual in May of this year, and then will take quite some time to mature because of the longer time course to an overall survival and DFS endpoint. And then the Ambassador study is a study that's going to be of a similar design, will follow almost straight on. It's now open in the United States. It's a phase 3 study with pembrolizumab versus observation, and it'll be a different population in the US because it'll be cooperative group, it'll be more real world than company-run studies. And then there's a University of California, San Francisco study from Larry Fong that we're trying to get off the ground at USC to do neoadjuvant before cystectomy for non-cisplatin eligible patients. And then in the space of muscle invasive disease, a SWOG concept that is now almost a trial called SWOG S1809, where chemoradiation is given with or without immuno-oncology therapy, and I can't remember what the agent is, but it's to look at that premise to see whether we can get an increase in bladder preservation. That study will incorporate our partners in NRG, which now includes what was RTOG. And then in non-muscle invasive bladder cancer, we've got a lot of activity occurring. I'll put some examples there. SWOG S1605 is a study of atezo in patients that have progressed subsequent to or on BCG. Has two strata of carcinoma in situ or just high-grade superficial disease led by Peter Black from the University of British Columbia. A commercial study, Keynote 57, which is with Pembro, and the ADAPT bladder trial, which was with durvalumab, are all of similar designs. And the FDA issued an RFA, if you like, a request for funding or request for trials in this area because there hadn't really been any significant advances, some would argue, since BCG. So these are sizable phase 2 studies, and if we get a non-progression with any of them that's significant, they'll get accelerated approval just like the metastatic disease.
So actually, for these early stage bladder cancer, we actually don't have solid data right now. And mostly we're still waiting for data to coming up. Okay, and I also know you have several answers for some of these questions.
Okay, so moving now into the first line. Well, the first line in combination with chemotherapy. So from that perspective, we have three important studies. The Danube study, which will look at solitary immunotherapy with CTLA-4 plus PD-L1 compared to chemo, which may change the way we treat the disease if it's positive. And we could see that later this year. Keynote 361 and Vigor 130 are trials that are similar in that we're testing chemotherapy with platinum and gemcitabine with or without an immuno-oncology agent, and also with an arm with just the immuno-oncology agent. Now that's interesting. We stratify for PD-L1 in these studies, but some of you who are doing Keynote 361 will be aware that the single agent arm of that study with pembrolizumab has been suspended, and we don't quite know why. We got an investigator letter, and I'm none the wiser. We haven't seen the data yet, but we're continuing to accrue in the group where it's chemotherapy plus or minus pembro, and that study will complete accrual also in the next few months. And in Vigor 130, which is with Atezo, also accruing extremely well. So we'll complete those studies and in the next year or two have significant data. So lots of new stuff coming.
So can I ask one question to Laura? In combination with chemotherapy, how do we differentiate side effects? Which side effects are chemo, which are from immunotherapy? Do you have any experiences?
Yeah, so that can be a distinct challenge in trying to separate and identify what the causative agent is for the side effects. You know what the common side effects of the chemotherapeutic agent are. So if they're similar with those, then that will be one clue. If you're unsure of the etiology and hold the immunotherapy, if that side effect resolves quickly, then it was likely related to the chemotherapy or something else. If it takes longer for that side effect to resolve, then it is more likely the immune therapy. And of course, if it worsens and you have to initiate steroids, then it is much more likely to be the immunotherapy. But you really have to do the detective work, and there's a lot of collaboration that goes on with reviewing lab tests, imaging studies, the clinical scenario, and really having that discussion to do your best. But we're still learning how to determine that.
Thank you. So, and then we have first-line monotherapy, of course. We have a lot of data. David, do you want to comment more on this?
Well, I think in the cisplatin-ineligible patients where we had a real problem with therapy, we've got some great data from Vigor 210 Cohort 1. The agent now available outside of trials in all sorts of places, including Taiwan. Keynote 52 data, I think, are also good, not quite mature yet. We'll see what that shows. And then for patients that kind of fall into the category of cisplatin ineligible or eligible, the combination of chemo, no current role, but those studies that I just talked about, Keynote 361 and Vigor 130 and the Danube, to come, and I think it'll be considerable interest in the next year to see how they turn out.
Okay. And of course, we have maintenance therapy. Actually, we are having some trials. You have any experiences when you're conducting these trials?
So the Javelin study looks at avelumab every 2 weeks versus placebo for a year for patients that have had chemotherapy and had some sort of response to see whether early immunotherapy works. Avelumab has some issues people may know with the infusion interval, but also the infusion reactions occur in about 30% of patients, and they're not immune. They're like we get with rituximab when we treat lymphoma. Certainly they're real enough for the patients. And then we're doing a Who's Your Oncology group randomized phase 2 study of Pembro versus placebo with a DFS endpoint, and that's accrued almost 100 patients, got about 20 to go, and that'll give an interesting read with that drug.
Thank you. And then we are talking about second line for MUC, and of course there are many data coming up. And the next question is about renal cancer and urothelial cancer treatment. Do you do PD-L1 testing, staining? If yes, which kind of PD-L1 testing do you prefer? Or can all IO agents use the same biomarker testing? David, you want to comment?
So I think until we saw Checkmate 214, the answer, and also the emotion study of atezo and bev in combination, I would have said no. And if going into those studies, if you had have asked me whether we'd be doing biomarkers in renal cell with all its heterogeneity and what have you, I would have probably said, get out of here. But I think there's evidence from each of those studies that PD-L1 may be important for patient selection, and the details are still to be worked out. Obviously, we use different assays. We use the immune cell assay with SP142 for the patients getting atezo, and we use the TPS assessment with nivolumab and ipilimumab. They're different antibodies. And in lung cancer, this has been looked at because they have the same problem. And the antibodies, in some cases, stain different things. So SP142 stains the immune cells and has a different characteristic. So at the moment, you need to do the paired antibody. The one thing we know is that if it's 0 with one of them, it's probably 0 with all of them. So that's about as far as we've got. And we are doing this in urothelial cancer, but we have no data looking at a set of patients who've been treated with one agent, looking at the 4 or 5 or now 6 or 7 different antibodies. So it's a problem. And it may be about to get worse because we're going to have a wave of agents, treatments coming through that are VEGF TKI and an IO. And if PD-L1 of something predicts that, we may end up having to do 4 markers to work out what our treatment should be and spending a lot of time on it. So renal cell just got a little bit complicated and has brought pathologists back to the table. Metastatic urothelial cancer, routine PD-L1 testing I do not do. That may change in time. Every time I think I'm on certain ground at the moment, a trial result comes out and the standard alters.
Okay, so you're trying to say that for renal cancer, PD-L1 or other factors may be predictive factors, and for urothelial cancer, it's only a prognostic factor.
Correct, yeah.
And you want to comment on this figure?
So this is from Bob Motz's update, or actually initial presentation of InMotion 151. And so this is the overall survival curve in the selected patients who are PD-L1 positive. And out of his 36 slide set from GeoAsco, I was trying to pick this one because I didn't want to present the whole thing, but this hazard ratio of 0.68 for overall survival in this secondary endpoint makes me think that you can select patients to get what's a pretty well-tolerated therapy of atezo and bev and be superior to sunitinib, which has been our standard. And so in the good risk patients particularly, I think this may end up being a standard, and I've done a lot of studies where I've looked at data sequentially, and people were wondering whether this is going to get approved by the FDA. This study, the curves are far enough apart for me to think it's not going to be an issue. I don't see the election result being turned around from here, even though this is an early read. So I think this is going to lead to approval, and PD-L1 assessment's going to be something we're going to have to do to work this out.
Because this is overall survival, so are you changing your treatment paradigm right now when you're treating patients like this?
I think, well, right now, no. We don't have the combination approved. We could try and get it. I think that if the data were filed, I could try and get this in the United States, and I haven't pushed the envelope on that. From that perspective, that's a little bit different to IPI and Nivo. And so for IPI and Nivo, we've started requesting, and we have our 10th patient on therapy now with the combination of Nivo and IPI. They're both approved drugs. Nivo obviously in renal cell cancer, and so that's changed my treatment paradigm for intermediate and poor risk. And I think we might have a slide to look at that. So this is a kind of a take on Checkmate 214, and this is overall survival in patients that are selected to be intermediate and poor risk. Now you can see here a victory for Nivo 3 and IPI 1. So it's low dose IPI. That's important because the toxicity is much less. Back in the old days, giving IPI 10 milligrams and originally not being able to give steroids on the trial was pretty terrifying. This is not without its toxicity, but nonetheless is manageable. So this in the intermediate and poor risk beats sunitinib. So the standard that's been up against all these other things is at last being beaten in overall survival. So this has changed my practice. So I'm starting to use this. What happens in a practical sense, and Laura can comment on what's going on at Cleveland, kind of on the East Coast, but we can get nivolumab approved by the insurers in the first line. So they'll approve nivolumab and they'll say, we're not covering the IPI. And so what happens is that the bar for patient assistance is kind of like Taiwan, right? It's based on income, is actually pretty high. I think it's maybe $125,000 a year. And that incorporates something like 80% of the population, if you look at them, and virtually all Medicare beneficiaries, what have you. So for the BMS assistance to get IPI, which is a relatively small dose compared to what we've done, we fill in the forms, and we usually, it's provided at this stage by BMS because the filing's current, and we have to provide some paperwork stuff for them, but it's actually fine. Just to be clear, in the good risk patients, sunitinib beats Nivo IPI. So there's a biology there. How PD-L1 fits into all that, because PD-L1 also predicts response to the immuno combination. We have to work that out, and we can have further discussion about that.
For all the audience here, if you have any questions, please, you can ask questions anytime. Laura, do you want to comment on this? Because in Taiwan or in all Asian countries, cost is always an issue. And how about in Cleveland, when you meet patients with cost issue?
Yeah, cost is definitely an issue, not only the cost of the therapy, but you want to make sure you're using evidence-based decision-making, that the patient is involved in that, and then the patient can participate in the financial discussion as well. But it is definitely an issue. And again, there is the side effect management and assessment, because you don't want to be putting them through therapy that's going to give them significant toxicity, increase their expenses, and interfere with the potential for the overall benefit. So it's an ongoing discussion.
It's about renal cancer. We have Capelson study, we have 214, Emotion 151. Which regimen would you prefer among these for treatment-naive renal cancer metastatic?
I have no idea, so I want to know what Laura thinks.
But you do have some random thoughts here.
I do.
Yeah, and I think the decision is up in the air. I don't think there's any evidence-based detail that we know to this point to make that decision. So it's really more clinician or comorbidities that will impact the treatment.
So I just want to say that these three therapies are fantastic in their own way. So, but it's a real challenge working out how to use them, manage the side effects, etc. And so, how do you select? Well, patients that have bone mets may do better with cabozantinib. for example. And so in the two cabozantinib studies, CABOSUN, which is the first-line alliance study, and then Meteor, which was the second-line study against everolimus, where it produced an overall survival advantage. If you look at the forest plots, the patients with bone mets actually did better in both those studies with cabozantinib, and met's important for bone mets. And so from that perspective, I'm starting to kind of use that as my first-line go-to when we've got spinal cord compression or bone mets or what have you. I think there's an evidence base there. The standard TKIs like sunitinib and pazopanib still have a role, and I think that particularly in good risk patients, and from that perspective, so I'm going to reverse it, but I may be shocked by the AV people. So Nivo-Ipi in intermediate and poor risk is interesting, but overlaps exactly with cabozantinib, where we have no comparative data. And then the selection using PD-L1 for the atezo-bev is very kind of interesting. So I don't know what we do with this. Will the market become segmented up, and we're going to need a rationalisation? But I'll be using each of these three therapies. I just need to work out in whom. And then there's another question, do I still give interleukin-2? Well, the answer is we've decided to continue our program mainly with research studies, and I seem to be being referred more patients for interleukin-2 because other centres are not giving it as much, and it's still a curative therapy, but very toxic.
So you're trying to say well, actually, most of centers do not use interleukin-2 anymore, but you're still using it. I know that in UCLA, or there are also Kabinovar, Dr. Kabinovar, they are still using it.
Well, Dr. Kabinovar has gone to the dark side. After 25 years at UCLA, he took his pension and he went to work for Genentech. So he's left practice. And he still calls me periodically. And their interleukin-2 program continues. They're a bit less busy than us. It tends to be run by the fellows, whereas I'm up nights running our interleukin-2 program, which I prefer not to be. But we've looked at what the immune response is to the new checkpoints and to interleukin, and it's different. And I have a couple of studies that we're doing we have a combination with an IO that we're going to do with a briefer interleukin, and then also a combination with a tinostat, where we published some phase 2 data with Roberto Pilli. So I think we've got an embarrassment of riches. And why do we opt to keep going? Well, my colleagues voted that I should keep doing it because they tend to send the patients to me. But we surveyed our referring base, and they said they would still send patients for IL-2 if we thought we could cure them, particularly in the good risk category. So we would give it instead of sunitinib or pazopanib. But it's an interesting discussion now, and I don't know what the answer is going to be in 2 years.
And I think that is the most important point, and that is 2 years from now, 9 months from now, it's going to be a very different discussion. You know, Ipi-Nivo has the potential, at least in our institution, to completely replace high-dose IL-2 in these patients. The cost of an inpatient, the interference in quality of life and working ability and things like that, as opposed to an outpatient therapy. I think the bigger question then becomes is, do we need to give it continuously? And so I think that there is many, if not more, questions that we're getting on the list of to be determined than we are necessarily answers in trying to understand how to treat these patients.
Okay, and next is when do we stop? When do we stop immuno-oncology treatment? Indefinitely, 2 years later, until a complete response, or any? David, you want to comment on this?
So we have no data in GU cancer, so immuno-oncology therapy joins love and herpes and is forever. Until we stop. Or we fall out of love, or we cure herpes. So we have some data with other things like melanoma and lung cancer, where if there's a deep response, we can stop, particularly with melanoma. But the trial in lung cancer, where they looked at stopping at a year, they had patients relapsing like half of them by 4 to 6 months. So there are different patterns. In urothelial cancer, we need to do some sort of trial and work that out. We had a year's experience with atezolizumab where there was no competition, and we treated, I think it was 56 patients, and 12 of them got to a year where they had major responses close to CR. So they did well in that year. For those patients, we said, well, we don't know whether to continue or not. 6 of them decided they wanted to stop. 2 of them have progressed, 4 of them not. And then we've got a responder to a re-challenge with atezo, and another one got another agent at a different institution, which is not one of the ones I would have picked, but they're stable, and it may be too early to tell in that patient. So we don't know.
Yes.
And I think one of the key things, and then we've got a question, I think one of the key things is continued enrollment in clinical trials. The challenge for us is going to be, as these drugs become approved, the referrals to do the clinical trials, or the involvement, and the patient's willingness to do the commitments for clinical trials really needs to continue so that we can better answer these questions.
And now we come to part B. It's about treatment beyond IO monotherapy. We are going to talk about combination, sequencing, and the role of surgery. Surgery. What is the role of surgery? We know cytoreductive nephrectomy for renal cancer in the era of targeted therapy and immunotherapy, the old immunotherapy. How about here, IO era? Well, a lot of comments from David.
Sorry. So I think we got to the point where if you got into the elevator at UCLA or USC, you got your kidney removed. If you came out, you only had to go 2 floors, and whoops, the kidney came out. Hopefully, they took the right one out. But the CERTIME trial, which was led by Axel Becks in Europe and accrued very slowly, looked at patients getting sunitinib and randomised them to get early cytoreductive nephrectomy or late, waiting 6 months. The results, whilst it closed early for lack of accrual, are sobering, because a lot of patients who have high volume disease and get a cytoreductive nephrectomy never get to systemic therapy. And the early death rate was something like 30%. And these are at good centres in Europe. So I think the role for cytoreductive nephrectomy right at the beginning is unclear with targeted agents. It's also unclear with the new novel immuno-oncology agents, and may still have a role if you're going to use the older immuno agents in your practice. For patients with metastatic disease, I like to give them immunotherapy and resect, unless they've got a few lung mets that can be resected, and we've got data that suggests there's a benefit. So I'll pick a patient who's got some metastases, give them interleukin-2, try and get a response. If it's not a CR, I'll resect them aggressively. Whereas I won't do that with VEGF drugs, because I think we're just temporising. So you stop the VEGF drugs, the cancer grows again. With the new IOs, I don't know, but we are resecting regularly for patients on chemo with urothelial cancer if they have a response in lung or lymph nodes, and they can often do quite well. So in the setting of the new IOs, what do we do? Well, you can give an IO and watch for response, and then potentially resect. I think that's okay. But you've also got this mystery ball of what's happening in the tumour. If they got immunoactivation and no tumour, do they have tumour that's actually growing that you can't see? And so for residual masses, we're now looking at our trial protocols of allowing them to be removed, which is what we do with chemo. So that's a bit of a change. And I don't know where we're going with this, but I think surgery has a role. We just need to redefine it.
Okay, thank you. Let's move on. The last part, treatment after IO. So how do we evaluate pseudoprogression? Now, is the pseudoprogression? And the answer from David is clear. It's most pseudoprogression is progression. David, you will have more comments?
No, I think it's overcalled. You see it more in melanoma and occasionally in renal cell, but in urothelial cancer, and I have a handful of patients who've had pseudoprogression. They've usually been scanned too early.
Okay, this question is for Laura. How do we differentiate diarrhea and colitis when patients are being treated with immunotherapy?
Yeah, I think that's a very good question. And I think the most important way to do that is, number one, with the assessment. Is the patient been compliant with their antidiarrheals? If they're due for therapy, then hold the immunotherapy if the diarrhea is grade 2. If the diarrhea with continued use of supportive care improves, and even if the patient's able to discontinue the loperamide or the other antidiarrheal agents, then it's likely not immunotherapy. The immunotherapy-related diarrhea may linger longer. It may improve slowly, but not as rapidly as non-IO-related diarrhea. And so that's where early follow-up will help identify that. Another way to help evaluate that is either colonoscopy or now more commonly CT imaging. So there's data now that demonstrates if you do CT scanning and you see mucosal changing in the colon, that can indicate the inflammation. And there you would have an easy, accessible way to identify the immunotherapy-related diarrhea or colitis. But otherwise, it's really going to be more an overview of the course of the diarrhea. Anything to add?
I think that's a pretty good summary.
So according to the CT images, how many percentage of patients would have a mucosal inflammation if they're receiving IO therapy?
I don't know that there was a specific in the article that I reviewed. I don't think there was a specific incidence. It was just more that you could utilize CT scanning as an alternative approach to the colonoscopy. Whereas if you may not see the colon changes on imaging, you may still need to do the colonoscopy and biopsy.
Okay. I believe this question has been addressed. Mm-hmm. Do you want to comment more about this?
Yeah, actually, I would like to comment. We had a discussion during the break about fatigue. I think fatigue, not only in our chemotherapy patients, but in our immunotherapy patients, is one of the most challenging side effects to really understand and to manage. I think one of the important things with immunotherapy is, although the incidence of endocrinopathies is low, that really needs to be looked at with immunotherapy. So doing your thyroid panel, your cortisol, ACTH at baseline, and then if a patient does present with fatigue, you need to circle back and reevaluate the potential that you've got an endocrinopathy contributing to the fatigue. And so that may be one way of differentiating. I know in some of the immune-related side effects, we do the Western segregation, the WSR test, or CRP. So trying to find some of these markers of inflammation may be helpful. But I think it's important to think about the endocrinopathies, even though the incidence is low.
So with immunotherapy, we have patients who have hypothyroidism as well as hyperthyroidism. Mm-hmm. Why is this? Is it because patients who have hyperthyroidism eventually will go into hypo?
I think that's a very true statement. It's just a matter of whether you obtain those thyroid tests at a time to capture the hyperthyroidism. I think you definitely have the hyperthyroidism. You have the inflammation initially, and then you burn out the thyroid and develop the hypothyroidism. So it's just a matter of whether you see the hyperthyroidism.